Okay. Um, Hello, everyone. We have today Dr. Freddy Sotelo and Mr. Jeb Dunkelberger. We're here to talk about an emerging company that is going to be solving a fundamental issue or challenge in the urgent care and emergent care space, and some of the key aspects related to that. So with that, I will like to introduce the guests. So perhaps it's best if they introduce themselves. So Dr. Sotelo, if you could introduce yourself and your background and why you started the company that we're going to be talking about.
Hi, Ken. Thanks for the intro. My name is Dr. Freddy Sotelo. I'm a board certified emergency medicine in Southern California. I've been practicing for 15 years, trained at Harbor UCLA, and I currently work. I've been an attending physician for about 12 years in one of the largest emergency departments in Los Angeles County. It's a trauma, stroke center, and STEMI receiving center. Over the course of my career, I have gotten involved more in acute care hospital administration, revenue cycle, best practices for reimbursement. And that experience, those two experiences combined, seeing where the emergency department has become the panacea of all healthcare problems, me and my partner decided to open up something new to really fill in those gaps of care when it's episodic, unplanned, is what we call the type of patient population. We're trying to help improve access. So this is to help primary care doctors, outpatient specialists, surgeons, and hospitals to sort of integrate and bring in value to the system.
Excellent. Thanks, Dr. Sotelo. And Mr. Jeb Dunkelberger, a little bit about your background and also why you have interest in the space that quantum healthcare is operating in.
Yeah, so my name is Jeb Dunkelberger. Throughout the course of my career, I've worked primarily in the United States, focused really in four key areas. So I started off in advisory consulting as a medical economist. I worked in the provider space, managing physician practices across 17 states in all different sorts of what we call value-based payment schemes. So reimbursement schemes that really incentivize quality and efficiency over just pure volume. From there, I moved into the insurance and payer space, working with both Aetna as well as Blue Cross Blue Shield. And then most recently, I've also started health plans. And then for a brief time in my career, I actually worked in the Silicon Valley with two digital startups. And so as I've worked in healthcare, the biggest theme for me has been how do we meaningfully and sustainably change the use of high cost facilities, especially for avoidable utilization. And there are a ton of solutions in the market today that focus on primary care. There's a lot of digital solutions as well, but there are very few clinical institutions and solutions that are focused on both low, mid, as well as high acuity patients. And what Quantum has been able to do is prove through their model that they are actually able to sustainably go after that patient demography, positively improve the patient experience, but more importantly, from a system perspective, reduce avoidable cost. And so from an insurance perspective, an employer perspective, and most importantly, an individual's perspective, it's a win-win-win. And so I've been fortunate enough to know Freddie for some time and serving as an advisor and looking forward to seeing as this company continues to grow.
Excellent. Thank you, Jeb. I'm going to call you guys Jeb and Freddie, if that is okay. Uh, my name is Dr. Ken Kengatharan. My background is in venture, healthcare, and biotech, having set up multiple companies, raised funds, prepared companies to go public, and I've moderated panels in life science and also healthcare related matters. And the guests asked me to moderate this discussion today. Um, so let's start with the fundamental question here, and perhaps this is for you, Freddie. What is the problem that you're trying to solve at Quantum? Clearly, you have a lot of experience having worked in the emergency space. And I'm sure the audience would like to know, what is that you're trying to solve?
Yeah. So if you look big picture, let's take the 30,000-foot view in the United States healthcare system. It's real easy to find on if you look at the CDC website what the current acute care landscape looks like. First is you're gonna wait. You're gonna spend 2 hours just waiting if you go to the emergency department. And almost half, I think it's approximately 46% of patients go to the ER because there's nowhere else to go. There's no urgent care open, there's no PCP available, there's no specialist available, there's no virtual visit available. So they end up going to this high cost center. That's nationally. In California, it's a lot worse. I think the average time is 3 to 4 hours. It's higher than 46%. So I saw that personally in terms of what ended up coming up through the door. You know, we were seeing our ER sees about 300 patients a day, and a lot of these are avoidable. They do need to be seen. I do want to underscore the fact that these patients do require an assessment, but the venue for them is very limited. It's just this ER venue. So these patients legitimately and medically necessary, I use that word, have to see somebody, provider, whether it's virtual or in person. And that's where the healthcare system falls short. I'll stop there in terms of talking more from the patient experience. That's the current problem now. Just to add to that, I would just say, premiums continue to go up. Healthcare networks are trying to adapt and increase access to primary care. But still, the access problem continues. The ER utilization continues to go up across the country. And so Quantum is out there trying to solve this problem, which nobody really is addressing currently in the marketplace.
I think that makes sense. So from your point of view, Jeb, why hasn't this problem been solved? Because it's an obvious problem, right? And it's been there for almost 20 years. This one of the reasons why urgent cares was set up or created, was trying to solve part of this problem. So why hasn't this been solved all these years?
Yeah, it's a difficult answer to give, only because I think that you can't look at it purely from a rational, logical perspective, because so little in the U.S. healthcare is rational and logical. I think that at the end of the day, the massive issue that we've had is, number one, at a primary care level, we have access issues throughout this country. There's no question about that. So that, number one, kind of starts the problem. Number two, once you move from there, you start looking at the macroeconomics of kind of what feeds the system. And what feeds the system is high cost care utilization. And so if you think about ERs as a converter or gateway for an admission, then attaching it to a large acute care center makes all the sense in the world. I think that what we've seen throughout the United States is that acute care centers are going through one of the worst financial periods in the history of US healthcare. And unfortunately, that will only continue. So anybody who thinks it's transitory and episodic, unfortunately, it's incorrect. We blame investment losses, we blame labor cost, we blame labor shortages, even COVID-related supply chain issues still being felt. But the reality is that the demography of the United States is changing, and the percentage of patients that are on government-funded lines of business, being Medicaid, Medicare, ACA, individual, those lines, that entire percentage is a growing percentage of our population, and the commercial population is dwindling or decreasing. And so the reason why I bring that up is because hospitals make money on commercial populations compared to government lines of business. And so anytime that you start disrupting the ER conversion into an admission, you are disrupting a massive piece of the local community infrastructure. And what I mean by that is that most hospitals in the United States are some of the largest employers in their local community. They depend upon admissions and inpatient utilization to derive revenue. And so what Freddie's daring to do is actually go out and say, this isn't about what's right or wrong for the company and the financials of those companies. It's about what's right or wrong for the individual. And he's prioritizing the individual's experience. And I think that there are too few doctors who are actually able to, one, have that vision, two, have the capital to actually go out and build it, and then three, have the actual energy and optimism that they can truly change something that is very large and very difficult to disrupt. So I think those are some of the reasons why you haven't seen the changes in the past few years, like what you're seeing right now.
And possibly, it won't gain traction for a while. Then, sounds like it's a pretty big nut to crack. So in this regard, Freddie, what is that you think that the urgent care, I guess they come under the acute care umbrella. Why is that the urgent care has not solved the ER side of the story, and that you feel confident that ContinuEM clinics, which is under the umbrella of Quantum, is going to solve?
I think the reason urgent cares just haven't hit the mark is really the scope of practice, and ContinuEM really is a care delivery paradigm shift. I know people talk about paradigm shifts all the time in digital health and primary care, but this one is a legitimate change in patient care. When you have an urgent care, most of them are staffed by mid-levels, nurse practitioner, physician assistants. They have daylight hours. So their scope of practice is very limited, and they do serve an important function, which is access to basic primary care physician issues that aren't acute or episodic. They're typically scheduled, controlled issues, and I think there is a space for urgent cares. But what I alluded to underscore before my prior comment, there's plenty of people in this country that suffer from chronic diseases. They suffer from routine needs. They do require an elevated level of service that you just can't find anywhere. I'll make my shameless plug that my wife is a family medicine doctor, so she did contribute to a lot of these ideas, and that it really is, we wanted to develop something that integrates with the three current pillars, which is the hospital and the hospital ER, the current urgent cares, and the primary care setting. And so the services we provide really enhance and connect with those three. And you do need to, our venue is resource intensive with advanced imaging, pharmaceuticals, cardiac monitoring, even minor medical and surgical procedures. But it is really needed. That's why they end up in the ER, because urgent cares fail to integrate with those levels of service that truly will help integrate with those three pillars in healthcare that don't exist. And that's why I think ContinuEM here, we're at the forefront to try to provide that care to improve access, but again, to provide value to everybody involved.
So clearly, in effect, what you're saying is that whatever that urgent care system is doing cannot provide, majority of what's available in an emergency care setting, and that you are trying to bridge that gap. So if you were to talk in terms of a patient journey, how would a patient journey in an ER setting be, different or similar to what you have in your clinics or centers?
Okay. I'll use our senior population example as because it's growing. They do require the most services compared to the rest of the population. And so for a senior to come in just feeling tired, and it happens to be in the evening at 7 p.m., their PCP is not going to be available. The urgent care will likely see the list of their comorbidities and tell them, we can't address you here today, Mrs. XYZ, you need to go to the emergency department. So this senior patient's going to end up going to the emergency department, and I'm just going to use my example of LA County healthcare affordability data that she's likely going to be there for 4 hours prior to getting any intervention, any full evaluation by a physician. And at that time, this patient, if they have mild dementia, if they have something, are going to likely worsen within the waiting room. Then they'll go in and see the physician, have a bunch of tests ordered. It's going to be very unintegrated, I would say, even with the best EHR. Um, Likely get pushed, what Jeb was alluding to earlier, and just to an admission for unknown reasons or for good reasons, or they're sent home. So that minimum stay in the ER is averaging about 8 to 12 hours. The continuum journey would be they could come to, we're open very late, so they could come here. We see them very quickly. Our physicians are trained in geriatrics, so they're emergency department physicians. So they feel much more comfortable addressing the complexities for seniors and their chronic illnesses. So we could see the patient there, have a more timely dialogue to then close the loop with their primary care doctor, which is probably that's the key that's missing in a hospital-based venue. Is there's no coordination of care. It's very busy, so it's all about throughput. It prioritizes throughput over the patient experience, and we're trying to reverse that at Continuum, where we prioritize the patient experience, what's right for them, what care could be best done at home, and then throughput is secondary. And those are the real differences that I think, from a patient journey standpoint, that really highlight how we're different from most venues around the country.
I see. And I assume that you're open 7 days a week, your centers.
Correct. Yes, and we offer in-person, and virtual visits.
And then from a cost point of view, how do you compare with emergency care, emergency room?
Our cost is significantly less. We're not associated with an acute care hospital venue. For example, in California, there's the Kaiser, Sutter, Providence, Tenet. We're not associated with them. So it's really a medical practice run by emergency medicine physicians on an outpatient basis. So our cost structure is still high compared to if we're comparing ourselves to a primary care office and urgent care, but it really pales in comparison to when you go to the next comparable venue, which would be a freestanding ER or a hospital-based ER or a micro hospital. The staffing costs, the 24-hour service is very costly, and it's part of the reasons, or one of the main reasons, it's really tough to be a hospital system right now. It's very costly to run all that.
I see. And if you were to take like three, key metrics that is important from a patient point of view, what are they, and how do you compare to, say, an ER from just those three key metrics?
The three key metrics is time to be seen, avoiding an ER use at all, and the one that we're really, really going into that nobody else does is actually reducing short stay admissions. Those three key factors are major in changing the care paradigm of how people even expect to get care delivery. We are trying to partner with somebody that could be at an arm's length, or not at arm's length, but we are partnering with somebody that can even help us with the at-home transition. So let's say we want to send them home, but we need a few things done. We now have a resource that could go and see the patient and close the loop with the PCP or the Medicare Advantage plan, which I think is really going to be a game changer in preventing acute care use for a lot of our seniors and all our patients in general. And I think that's how those would be the three key performance indicators I really look at, is just avoiding the hospital-based system, time to see a physician, and short stay admission reduction.
Yeah, I mean, based on what you're telling me, the key stakeholders in this case, the patients and providers and the insurers, payers, it seems like a no-brainer. So, Jeb, why aren't the payers jumping in and trying to help a company like Quantum up and running in a bigger way? I know they have a single clinic that's validating all the theory here, but what is that's perhaps stopping the payers, going big?
Well, a few things to kind of put in there. So one is that payers traditionally move extremely slow, and they do that for a few reasons. And as kind of a former CEO of more than a few provider organizations and payer organizations, I will tell you that the job of most insurance companies in America today is to act as the steward of the dollar, right? The watchdog of the spend. And so, in doing so, working with employers, they have to make sure that whatever they're approving and bringing into the network is indeed a value add. As you can imagine, there's a lot of new clinics, new diagnostics, new apps that are coming out. And as a payer organization, there are thousands of these things coming out at any one time that we have to work our way through and decipher what's valuable and what's not. The good news is that anytime that I and or Freddie and his team have gotten in front of a payer, there's been no question about value. That is the easiest conversation, actually. I think the second piece becomes the referral relationship. So as you establish these organizations, there's a direct to consumer play, but there's also a referral relationship that has to be established. That naturally takes time. You think about the relationships between primary care specialists and even the ERs and how the hospitals employ, hospitals and corporations employ about 74% of providers in the United States. And so to think that you can simply just drop in and disrupt that entire ecosystem overnight is kind of silly. So it takes a little bit of time for that. But then I think the last piece that most don't think about is that the payer organizations have a very deeply rooted relationship with their local hospitals. They negotiate very large contracts that typically are responsible for billions of dollars of spend. And those contracts are built upon relationships. And so as you can imagine, any time that a payer is endorsing or enabling more disruption in the market that may have a negative effect on a hospital, even though it's a positive effect on the consumer and the employer, it's one that must be judiciously reviewed before it is actually given the green light. But all of that to say, I think that we're moving at an incredible speed, relatively speaking. And it's been great to see the payer organization that I was with in California looked at Freddie and his team and what they were building, and it was a no-brainer to immediately have them in network. But I think what's going to unlock the growth for ContinuEM as we move forward is more payers realizing that if they can sponsor ContinuEM, they can also help inform the locations of which to build the sites and then begin to even build insurance products that offer things like $0 copays for going to ContinuEM, the same way we do a $0 copay for going to get a primary care annual wellness visit. And so we can use the financial levers of the insurance products to guide more members to these clinical sites. So I don't think that they're taking their time, but I also think that it's been difficult. As I said, 74% of providers are employed. But if you look at within emergency medicine, the number's closer to 90%. And so you don't have a lot of emergency docs that are actually able to do what Freddie's done. And so I think for so many payers, it's kind of like waking them up from a dream because they're like, we didn't even know this was possible. We didn't know that we could actually do this. So that's also been very enlightening as well.
Yeah, so I guess this is not like in elective, surgery or elective whatever, urgent emergent care. The patient has to get something done right away. So in effect, it's the patient who is actually influencing, what the payer needs to do. So could it be that the education needs to happen at the patient level first, and then providers and payers will follow, or does this need to come from a different direction?
I think you raise a really good point. And where I see is that you absolutely can create a groundswell. And I think that's what Freddie and his team have already done. They've gone out and proved that the model creates a lot of value. And you can see that from the reviews online, from the customers that they've already served. These are reviews that you would never see written about most any other clinical organization. Yeah, you'd think that like Amazon or Google or Facebook had some involvement with it because the user experience just seems to be very different than what has historically been seen. And so I do think we create a groundswell. What I would say is that what will actually unlock even more of that is if those individuals, as well as their employers, continue to get loud. I have seen payers make dramatic changes and very large strides when they know that their largest customers, which typically the most margin that you see in insurance companies is with the commercial insurance. So any large employer that it's a commercial insurance client that says, I demand that ContinuEM be in my network and be a $0 copay, you will see
Exactly.
the insurance companies rise to that occasion.
Exactly. And I think that's going to be critical, the education part. I know, Freddie, you and your co-founder, Dr. Bobby um, Masoudian, you guys went and created this as a way to convince people that this was possible, because you were clearly very frustrated with what was happening in the areas that in hospitals that you've worked in. Can you walk us through the journey that you guys embarked on and how you managed to prove your concept? And now it's more or less proven, based on some of the metrics.
Yeah, so it was several years in the making. I would say the idea probably 2015 was when we were talking about um, how do you solve this issue? Just, we knew a lot of emergency docs, the ones that were trying to change it, typically just did urgent care. And they found that there was just so limited and the quality really suffered because the payers just wanted to use it as, an access point for PCP. So they weren't expecting much and therefore not reimbursing much. And so we were trying to see, well, what is it that falls short? Because as an ER doctor, you also see a lot of urgent cares refer to emergency departments as well. And so it was a part when I had a conversation with Dr. Masudi and I was like, why don't we just bring all those tools that we use on a daily basis to the outpatient world? Essentially, that's how everybody sees it. In other words, outside of an acute care licensed hospital setting, but run by the staff that's there as emergency medicine physicians with our scope of practice. Our scope of practice is very broad. We can use and interpret imaging. We do procedures. We do minor surgical procedures, but we live in the hospital. We don't live outside the hospital. So it's like, let's do it out of the hospital. Why? And, of course, I ran this by my wife to make sure from a primary care doctor, she was going to be, you're nuts. I'm never sending anybody there. And she's like, oh, this would make total sense. So, it took a lot of work to put, our, raise together what kind of funding we'd need, what resources we need. And it did require a partnership because even though we're one center, we are vertically integrated with the laboratory, a pharmacy, physicians, nurses, the structure, and advanced imaging. So we had to get all those lines of services done at once. So it did require a lot of coordination. You realize that running a hospital is very difficult. I definitely appreciate that component, trying to build ContinuEM, but we decided the only way we could really make an impact to reduce the overburdened hospital system is to have the tools to deal with at least half the patient population that goes to the hospital in the first place. And urgent cares can't do that. They can only see about a quarter of those patients. So we're like, we can't be in urgent care. We're just going to continue to fall short. So we decided we took out our own, it's a personal investment between me and Dr. Masoudian. And we went and got our lease in January 2021. And we opened our doors August 2021. We have 9 physicians, ER physicians on staff that are part-time. They're all emergency medicine. They really love the new care paradigm. It did take them some time to learn this new paradigm. It's different for them, but they really enjoy it. They really love the positive feedback from the patients. Our nurses and medical assistants have been outstanding, and they really believe in the mission. And I think it's the combination of myself and Dr. Masoudian really reminding the team why we're doing this. And it really is, at the end of the day, to provide value to the entire system, but to their friends and families to avoid that high cost, inconvenient experience that most people deal with on a daily basis. So since August 21st, our patient volume continues to grow. We have strong financials for the future. And we're looking to lead the pack here in California and other parts of the state to really enhance the value for those three pillars, like I mentioned. We're here to help the hospital systems and their current issues by creating capacity and alleviating some of their problems that do create bad outcomes and poor patient experience. For the urgent cares, it can continue to help with the primary care doctors and that access for minor things, but then now they could refer to ContinuEM for some high level things that they don't think need to be admitted to the hospital. And more importantly, for the primary care doctors, they're probably suffering the most because there's very few of them and the demand is going up. And so they're going to really need a partner to really help them with expedited care, complex patients. And that's where I actually feel the most passionate about because there's such a huge shortage of PCPs. In my ideal world, I feel like emergency medicine could really be an olive branch to the primary care issues that are going on today. And here we are today and excited for the future.
And you've had some incredible growth in terms of patients walking in. Can you share some numbers on that?
Yeah, so our first year, we saw 11,000 patients. More importantly, we were the only outpatient site treating moderate to severe and mild COVID during the Omicron wave. So we partnered with the state to provide it for anyone. So that really drove our volume that first year. We're on track to see about 20,000 for this next year patients. Half of those are these are ER level patients. So these are patients that would have never been addressed appropriately in an urgent care or primary care setting. So we're already impacting the system nearby. Even speaking with the local CEOs of two hospital systems, they love our center. They don't see it as a negative. They are still impacted. Their ERs are still crowded, and they haven't really felt any impact in their ERs with ContinuEM being nearby. So I think we've just, again, this is a value proposition I really think is missing. And I think hospitals, even with us growing, I don't think they're going to see a huge impact from us because the problem is that big,
Exactly.
especially in California.
And then you're not really competing. I mean, that's important,
Yeah,
right?
they've been very supportive because they also hospitals now 2 day short day stays aren't attractive anymore because it's really impeding on their what I would call their sicker patients, their complex surgical patients. They can't even get those patients in because they're bombarded with these like minor 1 to 2 day stay patients, and we're an olive branch to them. Say, hey, we could expedite that for you. They've never seen that. And this is two CEOs from a publicly traded healthcare system that think this is amazing. And they were constantly in dialogue on how to have a strategic partnership. So I really think for forward-looking organizations, this is something that could really help the throughput and the type of patients that really do belong in a hospital.
Yeah, and then
And can I add to
sorry, go
that?
ahead, Jeb.
Because that is something that, I think a number of hospitals are realizing they cannot continue to build more infrastructure.
Exactly.
They can't afford to do that. And so, we've even seen a proliferation of something called a crisis stabilization unit, which is merely to get the recurring behavioral health patients out of the ER and into a dedicated location that is different than the ER, just to clear out space and access. And so I think, I'll echo what Freddie has said, that there are large healthcare providers that have, there's a side of them that definitely sees the competition, but I believe that always loses the moral high ground quickly because they're seeing it as this doesn't need to be admitted, but I'm admitting it because there's some sort of revenue tied to that. I think the majority of hospital operators and leaders are seeing this as we are an acute care provider. We want to see acute care patients. These patients that are mid to high level with the right clinical model wrapped around them do not need to be inside of our organization and inside of our sites. And so, again, I think part of this is going to be Freddie and team and all of our ability to actually showcase that value prop more so than the former. Because in order to make the most of the current infrastructure, which is a lot, I mean, we have a lot of built infrastructure, we have to be able to do this, but it's very difficult. And so the fact that Freddie's gained 20,000 patient visits with very little marketing, very little payer creation of products, I think just speaks to the value that individuals are seeing in this as well.
Absolutely. And I think there will be, like you said before, is a groundswell that we're all kind of waiting for as the number of centers like this gets, established in other areas. Now, talking about the infrastructure, obviously, one of the big question is then, is this very capital intensive to set up these centers? If I remember correctly, you're talking about low single digit to get going, even with that, you're more or less covering what 98, 99% of what's normally done in ER in terms of procedures. So would I be correct there, Freddie?
Yeah, I would say we can see of all patients presenting to the ER in California, I could confidently say we could see, evaluate, and treat about 87% of those. But then in addition to that, we could also address about 20% of those short stays as well. So that's a different patient population of people that actually admitted. So we can, just to summarize, address 87% of the ER visits end up going home, and about 20 to 25% of the short stay admissions. Um, and our cost to build is probably a tenth to 20% of it what it would cost a hospital system to go through the state. And again, I'm speaking for California. I know, just for the viewers, every state has different laws, and so the approach is there's nuance to the approach. But we're confident that our approach will always be significantly less costly than a hospital system's.
True. But then in terms of procedures that you can do in ER, that's about in the 90s, right? 90% of the procedures.
We could do about 90% of the procedures done in an emergency department. The only ones we can't are for the ICU critical patients. That belongs in the hospital.
I see. Now, I know you mentioned before, to me that you are trying to bring a tech component to, what you're doing. How is that going to help you, especially when you end up having multiple clinics? Starting with LA County and then expanding to California and perhaps other states in the future, which I know you want to do that.
Yeah. So I think everybody in this room knows that the EHR is a challenging and area for healthcare, from the physicians to the billing to the revenue cycle. And so one of the issues we're already encountering here at ContinuEM is we'd really like to have an end-to-end product from patient scheduling to the point to where the physician actually signs a chart. And my background with clinical documentation, the DRG system, and CPT coding, I do want to we're looking into a product using natural language processing and artificial intelligence algorithm that processes at real time for the doctor, so it helps them with their medical decision making and with their final coding diagnosis at the time they sign the chart. So we are looking for an end-to-end product that makes it seamless for the patient and the physician. So there's not too much fuss around the second step, which is the hidden part of healthcare, which is once a doctor sees you, it takes about 6 months for it to get processed and paid. We're trying to sort of simplify that for the physician so they don't have to think about that. But also adding, the biggest healthcare EHR in hospitals currently, I've experienced for 12 years. And they do try with alerts and some guidance and decision support, but it's far from robust. And we want to take it to the next level where it's driven by physicians to really offer advice based on what they're saying or typing in their note. Where our specialty is about risk stratification and mitigating risk and making sure patients don't suffer bad outcomes. So that's what a physician wants to see requested or recommended in this product. And I think just speaking with I did have a work group with family physicians and ER doctors, and they have voiced the way they would like to see it that would make it less painful for them. And that's the approach we're going to take to really ramp up as we grow. We want to have this EHR platform and this natural language processing AI really be the foundation of what drives efficient and safe patient decision making and care.
Absolutely. Now, as you mentioned before, and I think it's already been written, you're talking about only 20 to 30% of the patients that end up in the ER could be managed by urgent care. Do you see urgent cares being able to pivot and trying to do what you're doing, or what are the challenges they're likely to face, which makes it difficult for them to do that?
Yeah, it'd be very challenging for them to pivot. Their footprint is probably the first thing I would call out. The average size is about 3,700 square feet. Um, our exam rooms, for example, are sized as an emergency room size. That in and of itself would limit the amount of rooms you have in these current urgent cares. Um, Secondly, the tools that are required to do this increased scope of practice don't exist in the current urgent care, so a remodel would be a must. And then to do the procedures, the imaging, and the pharmacy, you need another 3 to 6,000 square feet. So the footprint's really difficult. And then also, our model is dictated by ease of access for patients. A lot of urgent cares are in malls, they're in airports, they're in maybe next to an urgent care. Some are in retail space, but we're really looking to be in like retail space. So it'd be real difficult for an urgent care to pivot and do what we're doing because it just doesn't have the mechanical or engineering capacity to do the imaging, pharmacy, and the monitoring and the procedures that we do. And second, the size is too small.
Yeah, and I've been to your center and I'm very impressed. Everybody gets a separate room, almost like concierge level, high quality care for everyone, which is, and I recommend anyone to kind of, if they're in the area, LA County. Right now you're in Lakewood, is your showcase center. You'll be expanding further. Now, for I know, Jeb, you have been in this space for a long time. Now, if you were to think about what's emerging, what's happening in the healthcare going forward. I mean, certain concepts like hospital at home, virtual care, and all these, are coming along. How do you feel that that uh, fits in nicely with what quantum is doing, and if quantum is in the right place at the right time as this new wave is coming?
Yeah, well, I mean, I think so much innovation within healthcare, like any other industry, is dependent upon major crisis, kind of just really acting as the impetus to drive something forward. And what we have in the United States right now is absolutely a crisis within our healthcare space when it comes to the cost of care. And so I think that you can look on the government lines of business, you can look at the Medicare trust, for instance. I mean, this is something that is debated at a presidential level right now, because as we look at 10,000 people a day becoming eligible for Medicare, there's just not enough money in the coffers to be able to pay for that level of care moving into the future. Certainly not at a rate that most providers would say would be deemed necessary to cover the cost. So then you have to ask yourself, is the cost appropriate? And that is where you begin to start seeing these evolutions take place, such as why are patients inside of an inpatient high cost facility when they don't need to be? And if we have things like ContinuEM proving that the clinical model does exist and that it is possible, then the economic crisis that we're under will probably give way to actually betting more, and to your exact point, being in the right place at the right time. So I think that number one is definitely the cost crisis. That's going to drive everyone to think differently. I also think, too, it's important to bring it back to the kind of the sociology behind all of this. Over 50% of working Americans today are millennial or younger. And the way that they interpret benefits from their employer are very different than their parents or grandparents. No longer do you see the loyalty. No longer do you see a quiet tone of this is just how it is, accept it for what it is. You see a lot more ranting and raving online. You see a lot more people taking to Twitter, Facebook, Instagram, and saying, this is an injustice. This isn't fair. The fact that my wages aren't going up because we're spending more and more and more money on the healthcare benefit, there's got to be a better way. And so I think that from a timing perspective, you have a financial situation. You also have a personality or persona that's coming up now, that's in their late 20s, early 30s, those people are soon going to be at director and vice president levels within many companies. And they're going to have the decision rights to start saying, I think we should do something different. And then that kind of gives out to the last piece, which is that we already see hospitals realizing that, if you kind of think about the hospitals built like a bunch of Lego pieces, hospitals are trying right now to topple over, break apart, and move into the community. And you see that being quickened by the fact that retail giants like CVS, Walmart, Amazon are also moving into the clinical space in a much more ambulatory focused fashion. And so I think what you're going to see is hospitals say, not only can we do a hospital at home, but we can do freestanding ERs and we can avoid the admission. And so again, I think that you have this kind of the triple effect of financial problems, personas that are much louder in the market than ever before. All at the same time, you see regulation and you see large hospital leadership realize that they have to move into home and ambulatory settings. So if I was a betting man, what I would look at right now is I'd say those three factors are three very large forces that when combined, they should be able to overlap. And what sits at the middle of that junction is actually the model that ContinuEM has designed.
Yeah.
So now it's a matter of just mass producing and getting it in front of the right payers, the right employers, as this quickly picks up speed.
So clearly, in this regard, urgent cares are not really, ready for it. One of the fundamental issues, and I have had personal experience in this, and I've heard from others, is that, hey, I turn up at urgent care, I don't see a doctor, and so in this respect, Freddy, what percentage of people who turn up in your center, you then send them to an ER? Because that's one of the biggest criticism of people turning up at urgent care.
Yeah. It's about 4 to 5%. It's really low.
That's really low.
Yeah.
Because that uncertainty is one of the things that patients will wonder about. If they, at any one time they go to urgent care and they get escalated to the ER, next time they're going to say, "Why can't I just go to the ER?" Right? This is a fundamental problem. Hopefully, that wouldn't happen in your case.
And we looked at it from a payer perspective, and we actually found that urgent care was increasing the cost of healthcare because you were getting a claim from the urgent care and more than 50, not Freddie's 4 to 5%, 50% of the time, those individuals were still going to the ER. And so you had an ER claim and an urgent care claim for the same individual. So it's almost like an expensive, version of triaging.
Absolutely. And then, of course, one of the other, as I pointed out, is the lack of physicians in many of the urgent care. So in this regard, Freddie, how are you, again, I'm sure many ER physicians may be listening to this video and podcast. How are you trying to attract these physicians and retaining them and, getting them to see a long-term career with your network of centers or, over time?
Yeah, I think with our specialty is going through quite a bit right now. There's a couple things is the burnout skyrocketed to a year into the pandemic, and then it continues to go up after the pandemic. The ER, I think there's somebody at Envision that said emergency medicine, we're turning into the police of medicine for patients, where we're seeing a lot of it's not a difficult patient population while trying to manage your physically, medically sick patients. So it's really becoming a challenging venue to work at. And then in addition to that, there's a real pushback within emergency medicine to join private equity funded emergency medicine practices. So that all has kind of sort of snowballed into a drop in actually emergency medicine residency filled spots this past year due to that, and there was a potential oversupply. So when we opened up ContinuEM, what's happened is we actually got a slew of applications because people have never experienced this type of model in their setting. It's a much more value-added encounter for the patient and the physician and the staff. that they see a future in it. And I think it will take time, sort of what Jeb had mentioned about it does take time with payers, it does take time with the consumer. It's actually going to take time with the emergency medicine physician to feel comfortable that they have, because we deal with emergencies. We're always thinking the worst case scenario. So to then pivot and do that same thought process and risk stratification outside the hospital does take a little bit of shifting in practice. And so that's been one of the features we're seeing, that once the physician accommodates for that, they really enjoy working here. And then they don't see a path outward. So we do want to tap on that. We do want to tap into, this is another way to be professionally fulfilled, is that you work in an emergency department and these outpatient centers. You are now talking to primary care doctors and specialists to close the loop. You're integrating care with those three pillars. And I think that and some ownership into the ContinuEM quantum model will only help this be physician-led care paradigm model, because this doesn't work unless you get the buy-in from the delivering physician. And being that this is a new model, Dr. Masudi and I really believe that it needs to be physician-driven, because they're the ones that will come up with the ideas to avoid the ER admission, to send them home. Or you could speak to the primary care doctor. You typically don't do that in the ER because you're resuscitating somebody. Somebody was just shot in the chest. You don't have time to deal with that 87% that isn't dying in front of your face. So now that they have time to actually do a legitimate workup in conjunction with the outpatient world. And that is really game changing from our specialty standpoint. And I think that's why we'll probably get more, what do I want to say? We'll probably get more in terms of recruiting. I don't see a challenge with it. Plus our added feature where we want them to gain as the ContinuEM and quantum gain, I think is a recipe that we're going to use to try to attract more physicians and retain them.
I see. I think in terms of compensation packages and all that, do you see that being, higher or comparable to?
I think it would be higher. As the reimbursement model changes, and with value-based contracts coming up, with accountable care organizations, we may take on more risk. So that's going to look different for the physician. How do they understand? They're so used to a fee-for-service model. I think depending on how all that looks for us, all that is to be siphoned to the physicians and our management team to reward. So, and whether it's stock options, equity, ownership, partnership, those are kind of the four things we're looking at. But those are the four things we're looking to offer physicians, so we retain them, so they feel they have skin in the game, not just in the patient care, but the delivery of this model at scale.
I see. And Jeb, I know we only have another few minutes left. In terms of acute care service provision, you have the urgent care, and then you have the emergency medicine, emergency room. Would you consider that quantum is creating a third avenue, almost like a whole new category, whole new class that is almost like the bridge between the two? Or is this something else?
Yeah, it's hard to say. I mean, if I had to really pinpoint it, though, I would classify it closer to the ER and the hospital, only because when you start looking at the additional service lines that quantum has been able to show that they can include, so imaging, lab, the pieces that also are complementary, but, important to call out, they can also stand on their own 2 feet. So a service line such as imaging, when you actually take that and you open that up as an outpatient, that's complementary. And so although we haven't really talked about that much today, there's much more similarity with a hospital and the services that you can get by being in a hospital facility than anything like an urgent care. I think an urgent care is like a diet, primary care facility. And I think people like to call it the opposite. But if you're not going to staff it with a physician, in some states, those nurse practitioners or APPs, they cannot practice at the top of their license. And I feel for them. They should be able to, but it's just it's it's the nature of the local environment that they operate in. And so I actually see it closer to the other side. And then also just to kind of build on top of what Freddie's brought up, my wife is also a physician like Freddie's, and she's a trauma surgeon. And so we hang out with a lot of critical care docs, trauma docs, and naturally ER docs. And as we begin to talk about this is a solution for the provider burnout. It brings back purpose, it brings back meaning, but more importantly, it also allows the individual providers to have a competitive salary and income, but at the same time be freed up from the bureaucracy that's sometimes tied to those larger organizations.
That makes sense. And then, so Freddie, as like the final words, if you were to look at the next 5 years for Quantum and ContinuEM growth plans, what do you want to achieve, etc., what would you say those are?
I would say expansion. LA County and Orange County. It's a large market with large problems. So I feel like with the population and the problems with healthcare are, they're linear. They're pretty similar. So we're looking to scale here to partner with health systems as we grow, and payers and providers and clinicians to really grow and to educate. This is a new model that took the primary care doctors close to a year to understand what we were doing. So our goal is to at least have close to 5 to 10 in both counties, while working with advisors such as yourself and Jeb and the rest of the team to see where else can we do this in an efficient manner, and faster. And again, I think the most important part with ContinuEM is I'm 100% confident that we could deliver the care and the service that we've done, that we've proved it here in Lakewood. The second part is really educating the environment, educating the payers, educating the patients, educating the doctors on what is it we're accomplishing. And that takes time. So I think that's where most of the energy I'd like to see spent from a ContinuEM spokesperson, if you will, because I think the product sells itself. I mean, based on our reviews, based on the outcomes, based on the feedback we've gotten from primary care doctors, this is what's needed for everybody involved. And so the next 5 years, we'd like to be at multiple sites in LA County, and maybe in conjunction looking at some other sites.
Okay. Well, there you have it. Finally, the so-called emergency room nut is going to be cracked. We have a real solution tested, tried and tested in LA, starting in LA County. I cannot think of any other place where it could be tested first. And a very dedicated group of physicians and advisors. And I'm hopeful that I think you're going to solve the problem that's been hanging around for almost 20 years, and in a very cost-effective way, and also with patient, interests, at heart. And so, wish you all the best, and I will continue to keep an eye on what you guys are doing and remain an advisor as much as possible. And I'm really excited, having been part of creating a set of clinics affiliated to Stanford many years ago. I know the value of creating and serving patients. So all the very best to what you guys are achieving, and hopefully we'll have another session like this, and perhaps in the future. You can tell us how you've actually cracked the nut, the emergency room overcrowding nut. Well, thank you very much.
Thank you, Ken. Thank you, Jeb.
Thanks.